from the American Academy of Pediatrics.
One of the challenges of pediatrics is navigating the inherent power imbalance between physicians and the children we treat.
A new clinical report examines the evolving dimensions in the pediatrician-family-patient relationship.
I think when we are thinking about crossing a boundary, we have to be very careful that it's not going to undermine the welfare of the patient in any way.
Plus, we'll look at a new definition of anaphylaxis.
There was a recognition that anaphylaxis is a universal thing across the globe, and we share a lot of medical information and we're learning from each other, so we should be talking about it in the same way.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a discussion about maintaining and managing boundaries in pediatrics.
David, have you ever had a hard time figuring out where the boundaries should be between your personal and professional lives?
Oh, I remember this sweet, sweet little boy I admitted several years ago with an abdominal mass that ended up being a severe form of cancer. And I knew his aunt from the community, and I followed the family's clinical odyssey as they posted about it on Facebook. But I never felt comfortable leaving even a little heart on their posts because I was involved in several of their admissions over time. Eventually, I did attend the memorial service, which was heartbreaking.
Ugh. David, that does sound really emotional. I have been friends with patient families on social media and felt the same tension. I've also found as my practice matures, I want human connections with my patients and their families because I think it makes me a better doctor. But is there a line you shouldn't cross?
Well, fortunately, we have some new guidance now in the form of a clinical report, New and Evolving Dimensions in the Pediatrician-Family-Patient Relationship, Maintaining and Managing Boundaries. And today we get to talk with both authors, Drs. Douglas Opel and Douglas Diekema, known as the Dougs in the pediatric bioethics community.
Dr. Douglas Opel is director of the Truman Katz Center for Pediatric Bioethics and Palliative Care at the Seattle Children's Research Institute and also professor in the Department of Pediatrics at the University of Washington School of Medicine.
Dr. Douglas Diekema is co-director at the Truman Katz Center for Pediatric Bioethics and Palliative Care and chair of the Institutional Review Board Committee at Seattle Children's, where he's also professor in the Division of Bioethics and Palliative Care and professor in the Division of Emergency Medicine. Dougs, welcome.
Thanks for having us.
Thank you.
The last policy statement on this issue came out in 2009, which now seems forever ago. Doug Opel, what were the key priorities of that statement?
Well, that statement addressed really important issues that still are relevant to the doctor-parent-child relationship, like accepting gifts from patients or parents as part of their wanting to show their gratitude to you as their pediatrician. So all of those really still remain relevant. But what we recognized is that as time has gone on, there have been added dimensions that require our attention as pediatricians regarding boundaries in that doctor-parent-child relationship.
I mean, it does feel like so much has changed. Doug Diekema, what were the major changes that inspired the new clinical report?
Well, you've alluded to a few of them. The big one, of course, is social media and its increased importance and use in our patient populations. And so many families are used to interacting that way. So we did have to sort of address boundary issues with this new technology.
And do you think families' expectations of their pediatricians have changed given that they're able to access them more easily?
I think they have. I mean, I've been doing this for a while. I think patients have gotten more comfortable with being more friendly with their physicians than they used to. I mean, back in the 70s when I was seeing a physician, it just felt, like there was a big difference between me as a patient and that person. But I think families now feel, in many cases, a lot more on sort of an equal level with their physician. And particularly in a small community, they may do other things with their pediatrician. Their kids may be at the same school, they may go to the same churches. So that also becomes important.
I know sometimes these days we feel kind of powerless, but in fact, there is still a significant power imbalance between providers and patients. Doug Opel, can you talk about that dynamic?
Yeah, I mean, we really as physicians sort of occupy a privileged position in society and are afforded really a great power in being able to help heal children who come to us who are sick, or help those who aren't sick continue to thrive and flourish. And that's an amazing privilege that demands some responsibility from us to protect the respect and dignity and trust that comes with that. So this is where boundaries come in. We want to ensure that in that privileged position, we do not do things that cross boundaries, that disrespect or compromise the dignity of patients, or erode trust that patients have and ought to have in us as physicians.
However, Doug Diekema, you were talking about how physicians are friendlier now and maybe more emotionally available to their patients. So how do we figure out the boundaries between sharing vulnerability and crossing an ethical line?
So it's not always easy, but I think, one of the things we tried to do in the guideline we wrote was provide some ways to identify where you're crossing the line in important ways. And a big one is when what you're doing has the potential to exploit the patient, when it has the potential for undermining trust that the patient may have in you, or when in some way it interferes with their physical and emotional well-being. So all of those represent things we need to pay attention to. The other way to think about this is that we're trying to create a medical home for our patients. So we do want them to be comfortable, but within a home, you can make people uncomfortable. And that's what we're trying to avoid in many of these cases.
Well, last year I ran for state senate, and at the time I was worried that this very public form of advocacy might interfere with some of my patient relationships. I'm not aware that it did, but how do we advocate for causes we believe in and still maintain healthy professional boundaries? For example, is it okay to wear the Vote ER badge during elections? Doug Opel.
This was a huge part of the guideline we wrote, and a lot of what we discussed. And we thought this was the very thing that you just said is such an important issue. And what we were hearing from pediatricians around the country that they were struggling with is some advocacy, because really what you just described by wearing that pin it's a form of advocacy, sort of with that message that you're bringing maybe on your lapel or your white coat, walking into an exam room, really does represent a form of advocacy. And is that okay? And we heard from a number of pediatricians around the country, given some of the social justice issues that were happening at the time and continue to happen, wanting some desire to do that, but also some recommendations for what was appropriate. So we acknowledged first that what we're really focused on in this guideline is what kind of advocacy is appropriate inside the medical encounter. Many have talked about the role of advocacy clinicians and physicians can play outside of the medical setting, running for, as you mentioned, a state office or other ways. And while that's not obligatory, that is certainly appropriate as citizens in the nation. What we wanted to focus on, though, is what is appropriate in the medical encounter. And in addition to the things Doug Diekema talked about, such as, is the action you're doing, the form of advocacy you're doing by wearing that pin, exploiting the power differential, causing some physical or emotional harm? And the other one I would add is compromising your capacity to be objective in the treatment of that child. So those three sort of elements are at play here. The other two that we thought, particularly for this advocacy issue, that ought to be considered is how central is what the message on your pin is for that child in front of you. So if it has nothing to do with that patient that you're taking care of, there's less justification for that message and that form of advocacy. And then also, importantly, is that message really representing a consensus issue or opinion from the Academy, right? So is there a written consensus position from the American Academy of Pediatrics on the message that you're including on that pin, wearing it in the exam room? If it is, it's much more justified to have that message on your pin, as it is really consistent with what the Academy's position is. So, for instance, get the flu shot. That's a message that's consistent with the Academy guidelines and would be very appropriate to bring that message on in form of a pin and advocate for that in that way in the medical encounter. Something like vote red or vote blue would not be, because there isn't a consensus position in the Academy on that issue. So those are other two really relevant things here. Does it really pertain to the health of the child in front of you? And does it represent a consensus position that really requires us to think about before we advocate in the medical encounter?
I like that framing in public health as well. And we have these advocacy roles as pediatricians. We also have our own lives that we can share with our patients. Doug Diekema, if a parent, for example, or a teen is struggling with something like painful periods, should I share my own use of birth control to help explain treatment and help that family?
I think it can be helpful. It also needs to be done carefully. When it directly relates to the patient's condition and the questions they may have and the concerns they may have, and where it builds trust, I think it's valuable. And I do this in the emergency department all the time. I mean, the classic example is that, for me, is that really competitive athlete who has just sustained an injury that, may keep them out of the state tournament, for example. And I think it can be helpful sometimes just to say, I've been there. I was an athlete myself. I coach high school athletics. I understand how frustrating this is for you. And I want you to understand that, my recommendations are designed to maintain your health so that you can have a good season next year. I think for many of them, it helps to know that their physician gets it. And the example you gave is another great example.
Joanna and I are pretty active on social media, and patients or their family members ask a friend or follow us sometimes. How should we navigate those requests? Doug Opel, thoughts?
I'd be really careful in doing so, particularly on personal social media accounts. There are a lot of things we post on our personal social media accounts, and when we are asked to friend our patients or their parents via our personal accounts, they then get exposed to our very personal lives, at least as we show them on our personal social media accounts. So that can really expose the biases we all have in who we are as people, compromise our ability to be objective, or at least have parents or patients perceive our ability to be objective as they continue to engage with us. So, consistent with other professional societies, we really recommended not friending patients on personal social media accounts. Now, ways you could do this is through a professional social media account and really direct them towards those accounts where they're much more curated and focused on our professional identities. And that can be a more appropriate place to engage with parents and families if they are requesting that from a social media standpoint.
Well, I am so glad we have this resource because I think about boundaries a lot. And I'd love each of you to share a final takeaway for our listeners. Dr. Diekema, let's start with you.
Maintain the focus on the patient. I think when we are thinking about crossing a boundary, we have to be very careful that it's not going to undermine the welfare of the patient in any way. That's our primary focus.
And Dr. Opel?
Yeah, I would agree with that. And I would just also acknowledge that boundary violations sort of exist on a continuum. There are boundary crossings that represent sort of minor violations, and then there are larger breaches that are sort of major violations. And, the criteria that Doug and I have talked about should be something we all think about, regardless of whether it's a minor or major violation. But there are times with potentially a boundary crossing or minor violation based on our assessment of those criteria. Is there sort of a net benefit to the patient? Does it not compromise our objectivity? And it has minimal ability to sort of compromise or exploit the relationship. Those minor boundary crosses always deserve scrutiny, but can be justified in certain circumstances. So thinking through, whereas major violations we ought likely never do. And so thinking about them as that continuum allows for that flexibility and nuance we were seeking in writing this guideline for pediatricians to sort of understand, because, there are many different dimensions to how we engage with families. And while we want to protect that relationship, the trust, dignity, and respect deserved, and keep patients at the, center, there are some times, like we've talked about, where we disclose a little bit about ourselves, but again, for the purpose of really deepening the therapeutic relationship.
Well, Doctors Douglas Diekema and Douglas Opel, thank you for talking with us today.
Thank you.
Thanks for having us.
To read the clinical report, New and Evolving Dimensions in the Pediatrician-Family-Patient Relationship, Maintaining and Managing Boundaries, go to aap.org/podcast.
Coming up, we'll discuss a new consensus report on anaphylaxis. Recently, my son Simon, who has eczema, though it's pretty mild, has been complaining that his throat feels spiky when he eats peanut butter and that he's eating a bunch of thorns. And so he's been avoiding it.
Ooh, you know what? I do find that a little concerning. And there are peanuts in so many things. Has he ever had an allergic reaction or anaphylaxis to any foods?
Thankfully, no, but I am on the lookout when he's eating things with nuts. David, should I be worried that with his mouth tingling that this is anaphylaxis? How would you define that?
Ooh, that is a great question, Joanna, and I'm sure you're not the only parent and not the only pediatrician who wonders about defining and treating allergic reactions.
So let's welcome Dr. Julie Wang to the show. Dr. Wang is one of the authors on a paper, Anaphylaxis, Definition, Overview, and Clinical Support Tool 2024 Consensus Report.
Dr. Wang is also a pediatric allergy and immunology specialist and a professor of pediatrics at the Mount Sinai Icahn School of Medicine in New York City. Julie, welcome to the show.
Thanks for having me.
Before this 2024 consensus report, how were people diagnosing and treating anaphylaxis?
So prior to this consensus report, there was a definition out there in 2006. The NIH, NIAID, and Food Allergy Anaphylaxis Network did put out a set of 3 criteria in which case anaphylaxis was highly likely. Subsequently, in 2020, the World Allergy Organization put out modified criteria, and instead of 3 clinical scenarios, they put it down to 2 scenarios based on advancing information, understanding about anaphylaxis. Because there were 2 different sets of criteria out there, there was not uniformity in terms of adoption of the different criteria. And so while there were criteria out there, there still remain some differences in perspectives and how people were labeling reactions as anaphylaxis.
Well, updating these criteria was an incredible endeavor. There was a writing group, international expert panels, and even patient involvement. How did you all come together?
Yes, this was a very big effort led by Dr. Timothy Dribbin. There was a recognition that anaphylaxis is a universal thing across the globe, and we share a lot of medical information and we're learning from each other, so we should be talking about it in the same way. And so this panel of 46 international experts from 14 different countries representing different specialties, from primary care to emergency medicine to anesthesia, because anaphylaxis, again, can show up in different locations, in the community setting, in the healthcare setting, different areas within the hospital system. So we needed everybody to kind of point to the same definition so that when we're talking about communicating clinical information between healthcare providers and patients, and then trying to have a global understanding of what is happening with anaphylaxis prevalence and what's the best way of managing, we wanted to make sure that everybody was thinking about anaphylaxis in the same way. And so the various fields recognized that we needed this. And so this was a lot of effort, but there was a lot of enthusiasm and motivation to get a more unified set of diagnostic criteria so that we were all speaking the same language.
And your group came up with a clinical support tool for all clinicians, not just pediatricians. It starts with recognizing anaphylaxis. How did the group define that?
So we use the 2006 criteria as a basis and incorporated the information that led to the World Allergy Organization's modifications. And that's where having the groups come together is super important. There was a lot of discussion, a lot of sharing of perspectives to understand why the modifications were made. And some people supported that, why other people maybe felt like the original version was a better approach. And then incorporating the feedback from a variety of medical organizations across the globe, as well as patient advocacy organizations, was helpful in defining, there were 3 parts for this group project. Was 1, the definition of anaphylaxis, and that's where the patient organizations did provide feedback. The clinical support tool that you mentioned is something that can be used in real time, but also be used as an educational tool to, again, make every person in the healthcare system think about it in the same way and practice in a more aligned manner. And the clinical support tool really points to that you need to know what to look for to be able to think of anaphylaxis as at the top of the differential. And then secondarily, once you've decided that anaphylaxis is very likely, then it moves into, what is the best treatment, which is epinephrine, and what the dosing would be for that.
And I know we can't describe the entire algorithm at this point, but can you at least remind us what organ systems are involved in anaphylaxis?
Yes. So anaphylaxis can affect any organ system. The skin, the gut, the respiratory system, cardiovascular system. And what the clinical support tool does is break it into 3 clinical scenarios, basically. The first is that you don't know about what allergen exposure occurred. You just see a patient presenting with multiple systems from different parts of the body. And so if there are a combination of skin symptoms, respiratory symptoms, and cardiovascular symptoms, kind of skin plus respiratory or cardiovascular, then hopefully anaphylaxis is pretty high on the differential in that scenario. So in scenario 2 is when there's a likely or known allergen exposure, in which case a combination of any 2 body systems would be sufficient for one to really think that anaphylaxis is likely. So a combination of skin, respiratory, cardiovascular, or severe GI symptoms. Now, of note, the GI symptoms, severe GI symptoms, is not part of that first scenario where there is no known allergen exposure, because for young kids, there are just so many kind of viral infections that can cause some sort of rash plus vomiting. And so that's why GI pops into the second scenario. And in the third clinical scenario is when you know that the child ate something that they were allergic to, or the person was stung by wasp that we know that they are allergic to. In that scenario, with a known allergen exposure, that's a very high pretest probability. So as soon as there are respiratory symptoms or cardiovascular symptoms, that's sufficient for us to worry that anaphylaxis is happening.
And I want to come back to these severe GI symptoms that you mentioned for a moment. How severe do they need to be to count?
Yeah, that's a great question. And that's obviously very subjective. In the original NIAID FAN criteria, it actually said persistent GI symptoms. And there was a concern that, you can have a very mild bellyache, but it lasts for several minutes. And that was really not what we worry about in anaphylaxis. So the kind of wording change from persistent to severe was made in the most updated clinical support tool. Now, because there is subjectivity, there is no standard grading scale for what a severe GI symptom is. It really is subject to clinical judgment. And again, this whole tool is a support tool. It is not a diagnostic test. And so clinical decision-making still has to be inputted while people are looking at these potential scenarios.
And when you talk about anaphylaxis in the report, you mention that it may cause death. Why is it important to mention that?
Anaphylaxis is potentially life-threatening, but Fortunately, overwhelming majority of cases of anaphylaxis, there is no fatality. The creation of the definition for anaphylaxis was obviously a group effort. And in this part of the project, the patient organizations provided feedback that they felt it was important to use the specific terms may cause death to communicate with the wider population that anaphylaxis is something serious and that requires urgent, immediate attention and care. And so that is why the specific words were chosen for the definition part of it.
And I'm afraid I already know the answer to this, but let's ask, is there a test for anaphylaxis? If I'm worried about it, should I just act?
Unfortunately, there is no diagnostic test. So there's no simple blood test, no saliva test. There is no test that will 100% tell you that anaphylaxis is occurring. Anaphylaxis is primarily a clinical diagnosis, but leaving it as clinical diagnosis is too nebulous, which is why the need for this clinical support tool is so important.
And you mentioned an EpiPen earlier. Is that still the way we would treat anaphylaxis?
Absolutely. So epinephrine is the number one, far and away, medication to treat anaphylaxis. Any medication that people might think about, steroids or antihistamines, those are far down secondarily to manage as adjunctive treatments. Epinephrine is by far the number one treatment agreed upon universally to treat anaphylaxis, and everything else is adjunctive. That is why only epinephrine shows up as the medication on this clinical support tool, and nothing else shows up.
And I know intramuscular is what is prescribed often and in my community, but is there any reason why you would use an epinephrine nasal spray?
Yes, so the new development in the allergy world last year was the introduction of a different method of delivering epinephrine, the intranasal epinephrine. And so in developing this clinical support tool, actually in the kind of additional information section below the clinical support tool, we do acknowledge that there are many studies looking at developing epinephrine to be delivered in non-injectable form. Intranasal is the newest one to be FDA approved. There are other ones under development. And so in the future, there may be other modes of epinephrine delivery. So up until last year, intramuscular epinephrine was the only choice. Now there is the intranasal as a choice for families to make.
I'm sure a lot of families are going to be relieved at that. Now, this is a really critical document that I think everyone should read because it will help save lives. But before they do you have any last takeaways to share?
Absolutely. Anaphylaxis is something that affects people of all ages. So this is not just a pediatric thing. There are many different triggers. I think as pediatricians, we think food probably is number one, but medications can cause anaphylaxis. Insect stings can cause anaphylaxis. There are people who have anaphylaxis for other reasons, perioperatively, for example. And so this is something that touches really any field in medicine. And so that's why it was so important to get a multidisciplinary group looking at developing this definition and the clinical support tool. And ultimately, anaphylaxis is something that is completely unpredictable, can happen in the community setting. And so having a definition for the lay public is also important for them to know about this. And kind of future work will be developing something similar to this support tool, which is intended for the healthcare audience, making an analogous one for the lay population so that when anaphylaxis does happen in the community setting, which it absolutely does, that people will kind of be informed and will be better prepared to manage.
Well, this was certainly very informative. Dr. Julie Wang, thank you so much for joining us today.
Thank you so much.
To read the article, Anaphylaxis, Definition, Overview, and Clinical Support Tool 2024 Consensus Report, go to our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, one of the wonderful things about having adult children is you get to hear them describe you back to yourself. And we had a bunch of the kids over for dinner recently with a new friend that they were trying to tell stories about our life in the past. And my older son, Sellers, said, Dad was just being himself, full of wonder at the natural world. And I was like, man, if that goes on my tombstone, I could think of worse things to go down as. Just somebody with wonder about the natural world. So that just made me smile for the rest of the week, knowing that that's how they see me,
That's so sweet. And my say is also about the natural world because I'm a snake mom now.
Oh, yeah.
And when you own a snake, that's like kind of all you want to talk about. And my snake had its first shed, which was so cool. It wasn't all in like one sleeve. So there's just like little pieces of the snake skin around, which excites the children. But it means she's like comfortable in her new habitat. So we're really excited that happened.
Don't let anybody tell you that snake ownership is not a personality, okay? It's perfectly fine.
I love her. She's great.
Well, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson.
Join us next week for a special Pathways to Pediatrics episode. We'll talk to a pediatrician who turned personal tragedy into life-saving advocacy. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.